You know, when we think about modern medicine, there's often this kind of built-in assumption that health problems are, well, visible.
Right. Yeah. Like you break a bone, it shows up on an X-ray.
Heck, or, you have an infection and your temperature spikes on a thermometer.
Yeah.
Even with cosmetic issues, I mean, the problem is literally right there on the surface.
You look in the mirror, you see a deep line on your forehead.
And if you want it gone, a doctor just gives you a quick injection to smooth it out. It's a highly visible, very straightforward transaction.
It really is.
But the moment you step into the world of chronic pain, specifically the kind of chronic pain that happens deep inside the complex musculature of the human body, you are suddenly like operating completely in the dark.
Yeah, and it's a profound shift in how we approach care, because when a condition is entirely invisible from the outside, it doesn't just make it harder to treat mechanically.
Right.
It often means the patient's experience is, misunderstood, severely underestimated, or honestly sometimes dismissed entirely by the medical system.
Which makes the topic of today's deep dive so incredibly compelling. We are looking at a treatment that sort of bridges those two worlds.
We really are.
When you hear the word Botox, you probably immediately think of the cosmetic application we just mentioned.
Yeah.
Freezing forehead wrinkles.
Sure. Or if you follow neurology, you might know it's used to treat severe migraines.
Yeah, exactly. But today, we are exploring a highly medical, deeply internal, and relatively hidden application. We're looking at how this famous drug is being used to treat chronic pelvic pain.
It is such a fascinating pivot. I mean, taking a compound that the general public associates almost strictly with, cosmetic dermatology and looking at its profound capabilities as a serious neurological and muscular intervention.
It's wild. And our guide for this deep dive is a brand new 2026 paper published in the journal Urogynecology.
A really landmark paper.
Yeah. It's titled Modified Delphi Consensus Guidelines for Pelvic Floor Botulinum Toxin Injection. And it was authored by Drs. Hufnagel, Torosis, and Ackerman. So our mission today is to extract the vital insights from these new guidelines. We want to understand how and why Botox is being utilized off-label for a deeply debilitating condition that affects, honestly, millions of women.
Millions! It's staggering.
But beyond just the drug itself, we're going to look at the fascinating, kind of messy reality of medical standardization.
Oh, absolutely.
We're going to explore why getting a diverse group of specialized doctors to simply agree on how to perform a procedure is, in itself, a massive leap forward for medical science.
Yeah, the journey to create these guidelines really pulls back the curtain on how clinical medicine evolves in real time, especially when doctors are, trying to help patients before the official regulatory frameworks have fully caught up.
Okay, let's unpack this.
Okay.
Because we are heading into the intricate mechanics of muscle tension, the unregulated landscape of off-label treatments, and the rigorous, sometimes really argumentative process of building a medical consensus entirely from scratch.
Let's do it.
So let's ground this by looking at the sheer scale of the problem these doctors are trying to solve. The numbers cited in this source material are just staggering to me.
They are.
Chronic pelvic pain, or CPP, affects approximately 25% of women.
Yeah, 1 in 4 women.
1 in 4. We are talking about an immense economic burden, too. It costs nearly $900 million annually in the United States alone just to manage it.
Just to manage it, right. Not even necessarily cure it.
Exactly. But pelvic pain is a massive umbrella term, right? What is actually driving that specific localized agony for so many of these patients?
Well, the paper zeroes in on a major, chronically undertreated culprit hiding beneath that broad umbrella. It's called myofascial pelvic pain, or MPP.
Okay, so breaking that down, myo meaning muscle, and fascia being the connective tissue surrounding it.
Right.
So we are talking about structural muscular issue here.
Exactly. We are essentially talking about severe, unyielding tension. The muscles of the pelvic floor become locked in this state of high tone. Yeah, they develop hypertender trigger points and debilitating spasms, and they basically lose the ability to naturally relax. I mean, imagine the worst muscle cramp you have ever had in your calf.
Oh, those are awful.
Right, but relocated to the core of your pelvic region, and it simply never goes away.
That sounds like absolute torture.
It is. And this chronic tension naturally cascades into a wide range of secondary issues. Patients experience severe urinary problems, defecatory dysfunction, and intense pain during intercourse.
I have to imagine the standard playbook for a doctor doesn't start with injecting a neurotoxin, right? If a patient presents with these symptoms, there has to be a less invasive starting point.
Oh, for sure. The first line of defense is usually conservative. Doctors will prescribe pelvic floor physical therapy to try and manually retrain the muscles to relax.
Okay.
But if physical therapy isn't enough to break that cycle of tension, they move to second-line therapies. This might involve vaginal muscle relaxants, oral pain medications, or injecting a standard local anesthetic directly into the most painful trigger points to, provide temporary relief.
But when all of those conventional methods fail, and the patient is still in agony, that is when Botox enters the picture as a third-line therapy.
Exactly. The paper formally refers to it as botulinum toxin A, or BTA.
Okay, I really want to understand the actual mechanics of the fix here. If I get Botox in my forehead, it freezes the muscle so I physically cannot furrow my brow.
Right.
Is the application in the pelvic floor relying on that exact same mechanism? Are we just, like, paralyzing the pelvic muscle so it literally can't clench?
Well, what's fascinating here is that the clinical benefit is actually driven by a dual mechanism. The paralysis is really only half the story.
Wait, really? Walk us through that first half then, the mechanical side.
Sure, so the mechanical effect is the one most people are familiar with. Botox works by inhibiting the presynaptic release of a chemical called acetylcholine at the neuromuscular junction.
Basically, it cuts the communication line between the nerve and the muscle.
Exactly.
The brain sends the signal to clench, but the chemical messenger never arrives, so the muscle just stays relaxed.
That is a great way to visualize it. It forcibly reduces the muscle tone and stops the spasm. And that mechanical relaxation takes a few days to weeks to fully set in, and the effect typically lasts for about 3 to 4 months before the nerve endings regenerate.
Okay, that makes sense. But you mentioned a second mechanism.
Yeah, and this is arguably just as critical for patients dealing with chronic pain. The toxin also blocks the release of excitatory and inflammatory neuropeptides.
That is wild. So it isn't just creating a physical freeze, it is actively shutting down the chemical alarms in the surrounding tissue.
It actively halts the inflammatory pain loop, because in chronic pain conditions, the constant clenching causes inflammation,
Right.
which creates pain signals, which then tells the body to clench even harder to protect the area. It is a vicious self-reinforcing cycle.
Oh, wow.
Yeah. By blocking those specific neuropeptides, the Botox essentially puts out the chemical fire while simultaneously forcing the muscle to let go.
I mean, if this compound acts as a highly targeted dual-action pain stopper for an issue causing this much misery, it sounds like an absolute miracle
It's
treatment.
going to be life-changing for sure.
Which naturally makes you wonder, why did this group of researchers need to write a whole new set of guidelines for it in 2026? You'd think this would have been standard operating procedure for a decade.
Well, the roadblock is a regulatory one. Using Botox for the pelvic floor is currently considered off-label.
Right, okay.
It has not been officially FDA approved for this specific anatomical use. And in the medical world, when a highly effective drug is used off-label without official clinical guidelines, the treatment landscape becomes incredibly fragmented.
Because every doctor is basically out there operating on their own clinical intuition.
Exactly.
They know it works for some of their desperate patients, but they don't have, like, an official instruction manual to follow.
Right. They are relying heavily on anecdotal experience. And when you leave complex procedures to individual intuition, variations inevitably creep in.
I can imagine.
One specialist might decide to use a massive dose of the toxin, while another uses a very conservative amount. One might dilute the drug in a large volume of saline, while another keeps it highly concentrated. They might even be targeting entirely different muscle layers.
And from a scientific perspective, that makes studying the treatment almost impossible.
Oh, completely.
If you are a researcher trying to gather data to prove to the FDA that this works, your data pool is a complete mess. You can't compare the outcomes of a patient in New York with a patient in California if their doctors used entirely different recipes.
Exactly. It creates a wall of noise. You end up with mixed trial results and massive difficulty proving efficacy, which completely stalls the path to widespread approval.
Wow.
So the authors of this paper recognize that to ever get this treatment accessible and covered by insurance, the medical community had to standardize the procedure.
They needed a unified rule book. And the way they went about writing this rule book is fascinating. They didn't just, lock 5 friends in a conference room to hash it out.
No, not at all.
They utilized a very specific, rigorous process called a modified Delphi method. I want to dig into this because it explains so much about how medical consensus is actually forged in the real world.
Yeah, the Delphi method is a really cool structured communication framework. It's designed specifically to build agreement among a panel of experts, especially in areas where hard randomized trial data might be lacking.
Okay.
So the researchers started by identifying top clinicians across the country. They deliberately sought out a mix of voices, mostly U.S.-based obstetrics and gynecology doctors working in academic settings.
Right.
But they also made sure to include private practice physicians and urology representation.
Because they wanted to ensure they weren't just getting this ivory tower academic perspective, right? They needed doctors who were in the trenches seeing these patients day in and day out.
Exactly. Ultimately, 18 highly specialized experts agreed to participate. The researchers then guided these experts through 3 distinct rounds of electronic surveys between September 2023 and July 2024. But the most crucial element of the Delphi method is that the voting and the feedback are completely anonymous.
You know, that structural choice makes so much sense when you think about the psychology of highly accomplished people.
Oh, for sure.
Because in a traditional meeting, the doctor with the loudest voice or the biggest reputation or perhaps the largest ego.
They can easily dominate the discussion and sway the room.
Right. Anonymity completely removes that social pressure. It forces every single doctor to evaluate the proposed guidelines strictly on their clinical merit.
It levels the playing field entirely. To establish an official consensus on any given statement, the rules required at least a 70% agreement among the panel.
Okay, 70%.
Yeah. If a specific technique or dosage didn't hit that 70% threshold, the statement failed. The researchers would then analyze the anonymous feedback, rewrite the statement to reflect compromises, and put it back to the panel for another vote in the next round.
It is literally a process of systematic distillation.
Yes.
So the final blueprint we are looking at in this paper isn't just one brilliant doctor's theory. It is a hard-won collective agreement.
A true consensus.
Let's look at the actual medical meat of this blueprint, starting with patient selection. Who exactly is the ideal candidate for this treatment?
So the panel reached consensus that Botox is appropriate as a third-line therapy for high-tone pelvic floor dysfunction and myofascial pelvic pain.
Okay.
They also agreed it should be considered for a few specific related conditions. Those include involuntary vaginismus, which is a condition involving severe, painful spasms upon any vaginal penetration.
Right.
Also vestibulodynia, involving chronic pain specifically at the vaginal opening. And anismus, which is essentially dysynergic defecation, where the pelvic floor muscles fail to relax normally during bowel movements.
Basically, the consensus covers any condition where the pelvic floor musculature is chronically locked up and causing functional failure.
Exactly.
Was there anyone they explicitly excluded? Like, did they agree on when not to use it?
They did. The experts explicitly agreed that Botox is not a therapeutic option for targeted groin pain, such as ilioinguinal pain. The treatment needs to be focused on the pelvic floor dysfunction itself.
Okay, so we have the right patient profile. Now the doctor actually has to perform the procedure. And here's where it gets really interesting to me, just thinking about the physical logistics.
Yeah, it's tricky.
You are a doctor preparing to inject a highly potent neurotoxin into a complex, tightly packed, entirely internal web of muscles. Logic suggests you would need incredibly sophisticated targeting gear to make sure you don't hit the wrong thing.
You'd think so.
Are they using like MRI machines or real-time ultrasounds or electromyography to map out the electrical signals of the muscle spasms?
That would be the logical assumption for such a delicate procedure. But the consensus among the experts overwhelmingly said no. Advanced, high-tech imaging is not required.
Wait, really? How do they possibly find the right spot without a visual guide?
The consensus dictates that simple palpation during a pre-procedural physical exam is entirely sufficient. The doctors are essentially using their hands to map the pain. During a pelvic exam, they rely on their anatomical expertise to physically feel for specific hypertender trigger points or tight bands of muscle tissue.
That is incredible.
Yeah, they are assessing 4 key muscle groups specifically: the puborectalis, the pubococcygeus, the iliococcygeus, and the obturator internus.
I see. So rather than looking at a screen, they are feeling for the topography of the tension. They map out exactly where the muscle is rigid and painful, and they target the needle directly into those tactile trigger points.
Exactly.
It's a highly manual, highly skilled assessment.
It is. However, the panel recognized that this manual mapping isn't always possible. So they agreed on a crucial exception, which they call a templated injection pattern.
What triggers the need for a templated approach?
Well, there are situations where a patient has global tension, meaning the entire pelvic floor is locked in spasm, rather than just a few isolated trigger
Oh,
points.
that sounds awful.
It is. Alternatively, a patient's pain might be so extraordinarily severe that they simply cannot tolerate a probing physical exam while awake.
That makes total sense.
Right. So in those cases, the doctors agreed it is appropriate to abandon the discriminant trigger point mapping. Instead, they use a standardized templated grid pattern to blindly inject all the major muscle groups, typically while the patient is comfortably sedated in an operating room.
That is a very compassionate allowance. You don't want to subject a patient to an agonizing physical exam just to find a trigger point if their entire pelvic region is already inflamed.
Exactly.
But mapping out where the needle goes is only half the battle here. The panel also had to agree on exactly how much neurotoxin to push through that needle. Because, if a doctor accidentally paralyzes too much of the muscle network that controls basic bodily functions, the patient is going to trade their chronic pain for a completely different set of devastating problems.
Oh, absolutely. The margin for error requires absolute precision. Dosing in this region is incredibly delicate.
And the numbers they finally agreed upon are very strict, right? The panel established that the total dose for a single patient session should be between 100 to 200 units of Botox.
Right.
And they explicitly noted that the dose should rarely, if ever, exceed 300 units at one time.
And that total volume is carefully divided. The recommendation is to inject 20 to 50 units per individual muscle group.
The paper also placed a heavy emphasis on the concentration of the liquid. They agreed the concentration should be 10 units per milliliter, which keeps the actual physical volume of fluid very low, only about 1 to 2 milliliters per injection site.
Yes.
Why does the sheer volume of the liquid matter so much, assuming the total units of the active drug remain the same?
It fundamentally comes down to managing diffusion. Think about how liquid behaves in soft tissue.
Okay.
If a doctor mixes the Botox into a large volume of saline, say 5 or 10 milliliters, and injects it into a tight space, that large volume of liquid is going to spread out and seep into neighboring tissues.
I see.
And the neurotoxin will drift right along with it. It might travel into muscles the doctor never intended to target, potentially causing severe unwanted weakness. By keeping the drug highly concentrated in just 1 or 2 milliliters of liquid, the toxin stays anchored exactly where the needle places it.
That makes perfect sense. You want a sniper rifle, not a shotgun, when you're dealing with a paralytic.
Exactly.
So we have the dose and the volume. How is it physically delivered?
The primary route of delivery is transvaginal. But the most interesting consensus point regarding delivery is that the injections should almost always be performed bilaterally.
Meaning on both sides.
Right, meaning the doctor treats both the left and right sides of the pelvic floor simultaneously.
I have to admit, that feels really counterintuitive.
How so?
Well, if a patient comes into the clinic and says, the burning tension is entirely localized to the left side of my pelvis, my right side feels completely normal, why would a doctor inject a neurotoxin into the healthy right side?
Yeah, it sounds odd at first. But if we connect this to the bigger picture of how the human body handles structural loads, the logic becomes really clear. You have to visualize the anatomy.
Okay.
The pelvic floor isn't a collection of isolated strings. It is essentially a continuous, dynamic, muscular hammock that supports the weight of the pelvic organs.
Oh, I see where this is going.
Oh.
If you loosen one side of a hammock,
Exactly. If you inject a paralytic into the left side of that hammock, those muscles go slack. Suddenly, the muscles on the right side have to work twice as hard to maintain the structural integrity of the pelvis.
wow.
Several providers on the panel noted that treating only the painful side often causes the good side to overcompensate, spasm, and trigger a massive pain flare-up.
So you are basically just chasing the pain from one side of the body to the other.
Right.
Furthermore, creating that kind of muscular imbalance, a lopsided hammock, could cause temporary obstructive symptoms, right? Like suddenly struggling to empty your bladder because the mechanical angles of the pelvic floor are completely skewed.
Precisely. Treating both sides maintains the structural equilibrium. It is all about balancing the load.
That is brilliant.
And regarding the overall safety of this procedure, the profile is remarkably strong. Because the consensus guidelines keep the dosing strict and localized, severe adverse events like an ischiorectal fossa abscess, which is a deep tissue infection, are exceptionally rare.
That's reassuring. What about the milder side effects a patient might expect?
They are generally self-limited. Patients might experience temporary constipation, transient urinary retention, or maybe mild stress incontinence.
Okay.
But because the pharmacological effect of the Botox naturally wears off in 3 to 4 months, any unwanted weakness or functional issue will also resolve on its own.
That makes sense.
Yeah, and because of this strong safety profile, the panel agreed the procedure can safely be done right in the office with local anesthetic, though the patient's individual pain tolerance ultimately dictates if an operating room is necessary.
So the Delphi panel successfully forged a robust, highly detailed rulebook. They achieved consensus on the patient profiles, the specific muscles, the precise dosing, the liquid volume, and the bilateral approach.
A huge accomplishment.
But as we mentioned earlier, when you put highly educated, highly specialized experts into a room together, even a virtual anonymous one, they're eventually going to clash.
Oh, inevitably.
Let's look at the no consensus zone.
Yes. These are the critical areas where clinical opinions remain sharply divided, and the survey questions just failed to hit that 70% threshold.
For instance, only 53% of the panel supported administering a pudendal nerve block, a major numbing procedure, at the exact same time as the Botox injection.
Right.
And only 55% supported diluting the Botox with an active anesthetic like bupivacaine, rather than just using standard saline. But the debate that really stood out to me involved the concept of a predictive test.
Ah, the local anesthetic test run. This is perhaps the most fascinating part of the paper because it perfectly captures the friction between scientific theory and clinical reality.
Set the stage for us. What is this test run, and why did it cause such a massive split among the experts?
Well, in practice, some doctors will inject a patient's painful trigger points with a short-acting local anesthetic, like lidocaine.
Okay.
If the patient experiences immediate temporary relief from that lidocaine injection, the doctor interprets that as proof that the underlying pain is muscular. They then use that successful test run to predict that a subsequent Botox injection will also be successful.
But this panel of experts couldn't agree that this is a valid approach.
Right, because this raises an important question about fundamental pharmacology. Scientifically speaking, the panel agreed that a local anesthetic injection does not accurately predict whether Botox will work.
Why not?
The two drugs operate on completely different mechanisms. Lidocaine simply numbs the nerve instantly, blocking all sensation for a few hours. Botox, as we discussed, alters the presynaptic release of chemicals over a period of months. You cannot scientifically look at the success of a temporary numbing agent and guarantee the success of a long-term neuromuscular block. The clinical data simply doesn't support a direct correlation.
If the science doesn't support the correlation, why are so many highly trained doctors still stubbornly insisting on doing the lidocaine test? The text of the paper actually addresses this, and it points to a very raw, practical reality.
It absolutely does. It comes down to the grim reality of healthcare economics.
Yeah.
Because using Botox for pelvic pain is still technically off-label, insurance companies frequently refuse to cover the cost of the treatment.
Which means the patients sitting in these clinics are being asked to pay completely out of pocket for an incredibly expensive pharmaceutical intervention.
Exactly. Providers are looking at desperate patients who have been in pain for years, and they are asking them to spend thousands of their own dollars. So doctors still utilize the local anesthetic test.
Even though it's flawed scientifically.
Yes. Because even if the lidocaine isn't a scientifically flawless predictor of Botox efficacy, if it temporarily stops the agony, it provides a crucial psychological benefit.
Right.
It proves to the patient that the root cause of their suffering is indeed a physical musculoskeletal issue. It validates that the pain isn't in their head, and it isn't some untreatable organ failure.
And that psychological validation gives the patient the confidence they need to actually hand over their credit card and invest their own money in the Botox procedure.
Precisely.
It is a perfect illustration of the tension between rigorous, pure clinical data and the messy, deeply human reality of treating people within a flawed insurance system.
It shows doctors trying to care for the whole patient, not just the data set.
So looking back at everything we've unpacked today from these new guidelines, what is the ultimate goal here? What does this document actually mean for the millions of women quietly enduring this hidden epidemic?
It means the field is finally maturing. By establishing these standardized rules, agreeing on the exact doses, mapping the specific muscle locations, defining the injection methods, the medical community can finally execute high-quality, large-scale, multi-center clinical trials.
Yeah.
Every researcher across the country will finally be following the exact same recipe.
Which means the data they generate will be clean, comparable, and honestly undeniable.
That is the goal. They are aiming to generate what we call level I evidence. Once you have robust level I evidence, you have the leverage to take this treatment from an experimental out-of-pocket off-label option and transform it into an FDA-approved, officially on-label, insurance-covered standard of care.
Wow.
Yeah. This consensus is the necessary roadmap to getting these patients reliable, affordable access to a treatment that can truly give them their lives back.
Which is just an incredible trajectory. We started this deep dive talking about visibility,
Yeah.
about how society readily uses a powerful drug like Botox to smooth out the visible, superficial wrinkles on our faces, while profound structural, life-altering pain remains hidden in the dark simply because we can't see it.
Right.
But these doctors, through this massive, meticulous consensus effort, are finally building a framework to drag this hidden epidemic into the light.
Here, providing a concrete, standardized structure for something that has been invisible, ignored, and misunderstood for far too long.
I want to thank you for joining us on this deep dive into the evolving world of chronic pain treatment and medical consensus. But before we sign off, I want to leave you with a final thought to mull over. If a relatively common, heavily marketed cosmetic drug, something millions of people use simply to freeze a frown, can be quietly adapted off-label to solve a billion-dollar, heavily stigmatized chronic pain epidemic in women, what other miracle treatments are already sitting right there on the shelves of our pharmacies, just waiting for the right group of experts to look past the label and standardize their true potential?